Welcome everyone to Grand Rounds this morning. I know it was a late night for many of us yesterday, so thank you so much for joining us today. First, I want to acknowledge that these are very uncertain and stressful times for many of us. The department leadership is monitoring the election and welcomes any collective thoughts. Despite the uncertainty, our Grand Round schedule will remain unchanged to sustain our academic continuity. Also, I'm sure it is helpful for all of us to take some time and shift our attention away from the constant news feeds. I know that it is certainly for me. Next week, we will not have Grand Rounds in honor of Veterans Day. Then on November 18th, we'll have the Hadar Grand Rounds, and we will be hearing from Dr. Dorothy Hatsukami, who will be presenting on tobacco harm reduction. So with that, it's my pleasure to introduce today's speaker, Dr. Pim Cuijpers. Dr. Cuijpers is a full professor of clinical psychology at the Department of Clinical, Neuro, and Developmental Psychology at the University of Amsterdam. He also directs the WHO Collaborating Center for Research and Dissemination on Psychological Interventions in Amsterdam. Dr. Cuijpers specializes in conducting randomized controlled trials and meta-analyses on prevention and treatment studies for common psychiatric disorders across the lifespan. Much of his work is aimed at treatments of depression and anxiety disorders, as well as internet-derived treatments. Dr. Cuijpers has been remarkably productive. He's published nearly 750 peer-reviewed publications. Since 2004, he has been on the Thomson Reuters Web of Science list of most highly cited researchers. And so with that, it is my pleasure to turn it over to Dr. Cuijpers, and we look forward to hearing your presentation.
Thank you very much, Dr. Posner, and thank you for the invitation to give a lecture here. And I also want to thank Myrna Weisman for the invitation and for organizing this. It's too bad I cannot come over to New York. I hope we can do that quickly again when the corona situation is over. Yeah, it's nice that you're all here, because I do understand that this is a very special day for the US, but I also think for the rest of the world. I must say that I've been looking at the news all day too. It's 5 o'clock in the evening here. So, but well, what I want to do today is I want to talk about psychological treatments of depression. And I will start now sharing my screen so that you can see my slides. I hope that works. Yes, here we are. Yeah, so what I want to do is I want to talk about, as I said, about psychotherapy for depression. And I will mostly talk about a large database we have been collecting over the years with all randomized trials on psychological treatments of depression. And I started with that 14 years ago. And it's only part of my work. We also do a lot of research, a lot of randomized trials, mostly on internet-based interventions for depression and anxiety. And we do a lot of research in college students, for example, and in global mental health. But these meta-analyses are still my personal favorite, because they give an overview of the whole field. And that has all kinds of advantages, but also, of course, disadvantages. The advantage is that you step into a helicopter and can look down at the whole field, what's happening there. The disadvantage is that you're up there in a helicopter and you don't see all the details of what's happening on the ground. So it's, I think it's interesting because you look at it from a distance, but of course, there's a lot to say and a lot of disadvantages too. What I want to do today, I will briefly talk about psychological treatments of depression. Then I will focus on the question, are they effective? And of course, you know they are. Wait, I think, yes, okay. I think I have I hope I didn't have the wrong slides here. Okay, I will first talk about psychological treatments of depression. Well, first of all, I don't have to tell you that depression is a major public health challenge and that treatments are effective. That's not only true for psychotherapy, but also for pharmacotherapy. But the effects are modest, meaning that there is much room for improvement. And that's why I think it is very important to focus on what works, for whom does it work, and which treatments do work. And over the years, you see that many different types of therapy have been developed and tested in all kinds of different formats. And in this presentation, I will give an overview what we know about these different types of therapies, about these different formats, about all the target groups for which these treatments have been developed. So I want to go to the next part of my talk, and I will talk, that's psychological treatment of depression. First of all, if you're interested in meta-analysis, I wrote a book about that. It's free. You can download it from my website. It's a starting guide for people, for researchers who know how to do research, but have not done many meta-analysis before. And it leads you step by step through all the steps you have to take in order to do a good meta-analysis. For each of the steps in this book, I've also recorded a YouTube video where I explain what you should do in each of these steps. Last year, I also published with a few colleagues a book on how to run meta-analysis in R. And that's online, also freely available. If you want to have it in paper, you have to buy it. But if you can find the contents online. And if you go to my personal website, you find all these resources here. So as I said, what we did is over the years, we collected all randomized trials of psychotherapy for depression. And every year at January the 1st, we update the searches to see what new studies have been done in the previous year. I won't bore you with all the details of how we do these meta-analysis. You can read that in all our papers. And if you want to know more, you can go to the website of our project. It's called www.metapsy.org. We have an open website at the Open Science Framework where you can also find all the documents and data sets and all that. You can download all the data with a small delay. Maybe I can show you later. We work with effect sizes. I assume that you know what these effect sizes mean. They are the difference between a treatment and a control group in terms of standard deviations, which is nice for researchers. But if you try to explain what that means to a patient, then that patient probably won't understand what you're talking about. So what I try to do in this presentation is I will also present the outcomes in terms of numbers needed to be treated. How many people do you have to treat in order to have one more positive outcome than no treatment? Okay, this is the website from our project. It's you see the link, the URL here. And here you can actually access all the data of the trials comparing psychotherapy with control conditions. And I won't go into detail about that, but you can online make selections of studies and run a meta-analysis online without going to R or whatever. So if you want to know whether CBT is effective in older adults, you select these studies and run a meta-analysis online. And you can do that on your own with so all the data are there. Or if you want to know, is psychotherapy effective in East Asia, you select the studies in East Asia and run the analysis. Or do you want to know whether internet interventions are effective for perinatal depression? You select the studies and run your own meta-analysis. So this is new. We started with this in the summer, and we will update this with the latest data with some delay. So we update every year at January the 1st, and then we take that year to write meta-analysis about the new studies. And then at the end of the year, we will make the data public so that everybody can have them. And everything is double-checked by 2 researchers. So all the searches have been done by 2 independent researchers. So I think the quality of the data are pretty good. But that's about the data. But it's much more interesting to see what the data, what they say, what are the outcomes. And here is what you see is how many trials have been published over the years. This paper was published in 2015, but the trends you see here are still continuing. And what you see is that until the mid-1990s, almost all research was done in the United States. Since the mid-1990s, especially Europe, has also started to do a lot of randomized trials. And at this moment, the number of trials in Europe and the United States are very comparable. But you see also, especially since the 2000s, that there are more and more randomized trials in other parts of the world. That's Australia, and that's Western countries, so to say. But you see more and more trials in other parts of the world, especially East Asia. So in our latest update, we've separated trials in East An because the number of trials there are increasing rapidly. But overall, you see an exponential increase in the number of trials that are published each year. And that's also continuing after 2015. We see it's a bit slowing down since 2018, but still the updates, just the updates every year, are more and more work. So that's good for the field, but not so good for us because we have to do all these updates. So now, currently, we have more than 750 randomized trials in our database, and they have all kinds of comparisons. They compare psychotherapy with control conditions, with pharmacotherapy. They compare different types of therapy with each other. They compare group therapy with individual therapy, with internet-based therapy. We have trials in inpatients and outpatients. We have a lot of trials on psychological treatments through the internet without any human support. So we have all these different types of studies. And over the years, we have been able to do meta-analysis of all these different things. So this is what this is the most recent overview of the trials in our database. These are 357 studies with 441 comparisons between psychotherapies and control conditions. So waitlist, care as usual, pill placebo, or other control conditions. And well, as you can see, there are all kinds of different therapies, as you all probably know. CBT, but also behavioral activation, of course, interpersonal therapy, where you have a very strong research group on problem-solving therapy, non-directive supportive therapy, but also psychodynamic therapies, the third wave therapies, and life review therapy that's pretty well examined. It's mostly done in older adults, but also more and more in cancer patients, where you systematically evaluate the life of the client. And so you try to influence the evaluation of the life of the patient into a more positive evaluation. And it works pretty well. It's mostly used for milder depression, so not so much for moderate and severe depression, but the effects are pretty good. Of course, it depends on what kind of control group you use. Waitlist control group, they overestimate the effects in my view, because they stimulate people not to do what they usually do to solve their problems, because they will get this great treatment in a couple of weeks. And what we know, at least from research, is that the effects, if you compare waitlist control groups with care as usual or placebo control groups, then the effects are larger when you use waitlist control groups. We also separated out the different type of care as usual. So we say that no treatment is in fact also a type of care as usual, because people can get treatment anyway. So if they participate in a study, you cannot prohibit them or forbid them to find treatment elsewhere. So it's in a way, it's also care as usual. But we have also a lot of studies where psychotherapies are compared to care as usual in primary care, general medical care, perinatal care, in specialized mental health care. And what you see, this paper was published last year, and what you see is that the effect sizes do not differ across type of care as usual. What we did find is that there are large differences between countries, and that makes sense. Care as usual in the United States is not the same in primary care. It's not the same as primary care in China or in the Netherlands. So that's that, and then that all made quite sense. These therapies do not only have an effect on depression, but also on all kinds of other outcomes, on quality of life, social functioning, hopelessness, social support. Strangely enough, we found very few studies focusing on the outcomes of psychotherapy for depression on suicidality. That's strange, because if people are suicidal and have a depression, guidelines say that you should first treat the depression and then look at the suicidality. But so you would assume that there is a lot of research on the effects of psychotherapy for depression on suicidality, but there is not. So we really don't know whether that is effective or not. There is a small group of studies aimed at depressed mothers, which is also an interest of yours in Colombia, I know. And these studies, they show that if you treat depression in mothers, then you see that the mental health in their children also significantly increases, that the interaction between mother and child also improves, and that parental functioning is going better. The number of studies is pretty small yet, but this meta-analysis was published in 2015, and I know that a few new studies have been conducted, so that would be interesting to look at that also. One important question is whether treatments differ from each other. Do the effects are comparable, or are some treatments better than others? Well, we did one early meta-analysis in 2008, in which we selected all studies in which one type of therapy was compared with another type of therapy. So if the effect size is 0 after treatment, that means that there is no significant difference between therapies. In this meta-analysis, we found that supportive therapy was a little less effective than other therapies, and IPT was a little more effective than other therapies. the finding for interpersonal psychotherapy, we could not confirm that in later updates. So it's probably because the number of studies was pretty small and there was some bias in there. But in our latest meta-analysis, we couldn't replicate this. We do find that supportive therapy is a little less significant, less effective than other therapies, but that's also possible that that's caused because supportive therapy is often used as a control condition, and then it's not conducted well. So it's often used as a control condition in trials when people say, okay, we do in the control condition what you do in all therapies. So, and that's often supportive therapy. And then we compare that with the real therapy, which is CBT or I don't know what, doesn't matter. But then if you don't do the supportive therapy well in the control condition, you find that the other therapy is superior. But that's very well possible that that's caused by, the bad therapy given in these studies. So we're not certain whether this is true. It may be true that supportive therapy is a little less effective, but anyway, the effect sizes are pretty small, as you can see. We did a couple of years ago in 2013, we did with a Swiss group a large network meta-analysis of 200 studies, about almost 200 studies, comparing all therapies with control conditions and with each other. And there we found basically the same. No significant difference between types of therapy. And in network meta-analysis, you include both direct and indirect evidence. So you make optimal use of the available evidence you have. And so based on this meta-analysis, you could say, well, there's probably no difference between therapies either. We're updating this now with, we have stricter inclusion criteria, and we have something like 350 trials, so that's really a lot. And the first outcomes show that, so confirm these findings, that all therapies have comparable effects, except maybe for non-directive counseling. So is the dodo bird right after all? You know the story about the dodo bird, right? I mean, this is something coming up in the literature since the 1970s, referring to the Lewis Carroll's Alice in Wonderland. And when Alice and her friends were having a contest, and at some point the dodo said, well, that the contest is over. And then Alice asked, but who has won? And then the dodo bird said, everybody has won and all should have prizes. Well, maybe that's true for depression, but we're not completely certain. There are alternative explanations. It's also possible, as I said in the beginning, in the meta-analysis, you look from a helicopter view and you don't see the details of what's happening on the ground. And if you think of what happens in psychotherapy, it's very well possible that you have one therapy communicating with that one unique patient in a specific way. And that one thing that the therapist says at that moment makes a difference for that patient with those problems. And I mean, that's what happens in therapy. And what you do in meta-analysis, you throw that all out and you put everybody in randomized trials with a lot of people together. And then in meta-analysis, you take all these trials together and you crush it all in this one meta-analysis machine. But that doesn't matter. That doesn't mean that there are real important differences for some people in some situations, for some therapies, for some type of interactions, et cetera, et cetera. So we really don't know whether they are completely the same, these therapies. But if you look at meta-analysis, the overall effects, they're clearly very comparable across types of therapy. But is that only for type of therapy? Is it not, does it also matter how you treat, how you offer these therapies? And here I want to refer to a network meta-analysis we published last year in JAMA Psychiatry. It's only on CBT. We wanted to focus on CBT because that's where most of the studies are and where most of the different treatment formats are used. So in this network meta-analysis, we included 155 studies with 15,000 patients. And we included studies on individual CBT, group, telephone supported, guided self-help, and internet-based therapy. We considered that as part of guided self-help. Unguided self-help, so that's you apply a CBT therapy through reading things on the internet, how you can apply that to yourself as a patient, do all the tests, homework assignments, etc., without human support. And we included all studies comparing these different treatment formats with waitlist, care as usual, pill placebo, but also with each other. So studies comparing individual with group, telephone with self-help, etc., etc. Because that's what you do in a network meta-analysis. Basically, you do all these pairwise meta-analysis at once in one big meta-analysis. Here you see the network plot. So the size of the blue circles indicates the number of patients and studies in these conditions. And the lines, the thickness of the lines indicate how many comparisons there were. And what you can see here is that there is a lot of research comparing waitlist with guided self-help and group therapy with care as usual and individual therapy with care as usual. But there's no research directly comparing telephone CBT with guided self-help or unguided therapy with telephone therapy. But because it's a network meta-analysis, you can use indirect comparisons to estimate the difference between telephone CBT and guided self-help. So if you can compare telephone CBT with individual therapy, and you can compare guided self-help with individual therapy, you can make an indirect estimate of the difference between telephone CBT and guided self-help. So this is what we found. Here you see the different treatment formats with care as usual as a reference group. And basically what you see is that treatment format really doesn't matter as long as there is some human involvement. So group, you can apply CBT through groups, by telephone, individually, through guided self-help. And the effects do not differ significantly from each other. Unguided self-help was less effective than the treatment, than the other formats in which a human is involved. Unguided self-help was more effective than waitlist, but not more effective than care as usual. We have to, that's a little more complicated because I won't go into that, but we now find that this is probably not completely true, but I don't have the time to go into that. But we also do these individual patient data meta-analysis. I will come back to that later. So what we do find is that the dropout in guided self-help is somewhat larger in guided self-help than in other formats. So if you treat people through the internet, then you have to watch out that people don't drop out because the risk is higher. So what other things did we find for based on all these meta-analysis? So as I said, no relevant differences between therapies, no relevant differences between treatment formats, but we also have all these different study populations. So there is a lot of research in students, in older adults, in people with comorbid general medical disorder, in perinatal depression. And basically what we find is that there is no significant difference between psychotherapies in these groups and in other groups. So you can safely assume that psychotherapies have comparable effects on average in people with perinatal depression, women with perinatal depression, when people have a general medical disorder. What we did find is that the effects are possibly smaller in chronic depression, which makes sense. Unfortunately, the number of trials in chronic depression is pretty small. And there are a few trials in dysthymia, persistent depression, depressive disorder, which very small effect sizes. So we're not certain whether this is caused by these few studies on dysthymia and that there is no difference in other types of chronic depression. But you should, until now, the evidence says that possibly the effects are smaller in chronic depression. We also find smaller effects when people have depression and comorbid substance use problems. So the effects of treatments of depression are much smaller, and we find no significant effect on the substance use problem. So that's really something you should watch for. We also find smaller effects in subthreshold depression. So when people have symptoms but do not meet criteria for a disorder, that does make sense because they have less room to improve, so to say. So then it's yeah, you can expect that the effects are smaller. We also find smaller effects in inpatients, but that's probably because the control conditions are different. So people get a lot of treatment when they are inpatient, when they are in an inpatient setting, and then the room for improvement by offering them a psychological treatment, that's not so much. Interestingly, we didn't find an association between the number of sessions, and we only looked at individual therapy. We're now replicating that because this study was published in 2013. But what we found then, we included individual therapies with 6 to 24 sessions, and we did not find an association with the outcome. We also did not find an association between the effect size and the contact time. So the number of sessions times the length of each of the sessions. What we did find is that the frequency is related to the outcome. So if you give therapy twice a week instead of once a week, then the effect size goes up. And that's something we recently replicated in a new randomized trial in which we randomized people to therapy once a week or twice a week. And we could confirm that that's indeed the case, that the effects go up if you treat people twice a week instead of once a week. We also did one large meta-analysis in 2018 on psychotherapy for depression in low and middle income countries. And what we found is that the effects of psychotherapies in low and middle income countries is actually higher than in high income countries. And we separated out Western countries from non-Western countries, so Europe, United States, Australia, Canada, and compared that with trials in the rest of the world. And still the effects of psychotherapy for depression was higher in non-Western countries. That could be, the number of trials is not that large. I think we included 30 or 35 trials in low and middle income countries. The quality of the trials was not that high, so it could be related to the quality of the trials, but you can at least conclude that psychotherapies are not less effective in non-Western and low and middle income countries. There is something you should realize when you talk about meta-analysis, and that's what I talked about now. That was the good news about research on psychotherapies, because there is also bad news. And there are a lot of more methodological problems when you look at research on psychotherapy for depression. As I said, probably waiting list control groups overestimate the effects. I won't go into that now. But if you look at the quality which we assess with the risk of bias, the Cochrane risk of bias tool, then we found that 80% of the randomized trials has some risk of bias. We have the problem of publication bias, which reduces the effect size with about 25% in ADM studies, in antidepressive studies, but also in psychotherapy studies. And if you adjust for these problems, you see that the effect sizes drop about 50% after adjustment for these problems. And that's not a minor issue. So if you just look at the research in the whole field, that overestimates the effects of psychotherapies compared to the best research we have, so to say. So that is a matter of concern. Of course, you see this is improving the last couple of years with all the guidelines, etc. So, and we have enough studies of high quality which we can adjust for publication bias to see what the actual outcomes are. And they're still significant, and you still should send people to treatment. Okay, now I go to the next thing. Should we focus on, is psychotherapy more effective than pharmacotherapy? And what about combined treatment? We did a network meta-analysis about that, which was published this year in World Psychiatry. Here you see again the network plot. So we compared pharmacotherapy alone with psychotherapy alone and combined treatment. You also have this small group of studies in which people get psychotherapy plus pill placebo. And there are a few studies in which all of this is compared to pill placebo. In these analyses, we focused mostly on the three most important arms, and I will present the results of that. So psychotherapy, pharmacotherapy, combined treatment. And we had 101 trials, 12,000 patients. What we found is that combined treatment is more effective than either psychotherapy alone or pharmacotherapy alone. No significant difference between psychotherapy and pharmacotherapy at the short term. So that we took response, so a 50% reduction in symptoms from baseline as the main outcome, because then you can simulate an intention to treat analysis, and then you don't have to bother about dropouts. But we found comparable effects for remission, and when we looked at effect sizes and all that. And most studies were done in moderate to severe depression, very few in mild major depression. But we did have quite a few studies in chronic and treatment-resistant depression where we found very comparable results. We had a number of studies in severe depression, according to the Hamilton, still the same results. And we also had quite a few studies on longer-term outcomes. And there, again, we found comparable results. What we did find is that the acceptability, which we defined as study dropout for any reason, was lower in psychotherapy and in combined treatment compared to pharmacotherapy. So people stay in the study and probably in treatment longer when they get psychotherapy or combined treatment, which is, I think, also an important outcome. So I don't have that much time anymore. So I will go to the next subject. And that's that's one of the new types of meta-analysis, which are called individual participant data meta-analysis. So in these analyses, we write to the authors of trials and ask them to send us the primary data of these trials. And then we pool all these data into one big data set. And then we run new analysis. And basically, there are just normal meta-analysis because you do searches, you have a very clear research question, you look in the literature, you rate the quality, risk of bias, etc., etc. And then you get a certain amount of primary data and some you don't. But for the data you get, you make that one big data set. The nice thing is that you can do the analysis in the same way across all trials. So you can impute missing data, you can run the analysis in exactly the same way across trials, but you have much more statistical power to look at individual characteristics of patients, whether they predict outcome or not. And that's one of the main reasons why we do that, because conventional trials are usually powered to find an effect. They're not powered to find moderators or predictors of outcome. And if you look at simulation studies, the number of people you need to find a significant moderator of outcome, that's much more than what you need to show an effect of the intervention. But if you pool all these data in an IPD data set, you do have enough power. And the nice thing is that you can also look at rare outcomes, for example, on deterioration, which is pretty rare, but it happens. About 5% of people in therapy, they get worse significantly. And so what you can do in these IPD network meta-analysis is that you, IPD meta-analysis is that you can look at these this kind of outcome. So I will go through it quickly. Of course, it's much more work. So we now have a few of these projects going on, and I will show a little of it, but there's much more coming. And so many people in my group are now focusing on this kind of research because it's really a major step forward. So this is one meta-analysis we did on self-guided internet interventions, which was published in JAMA Psychiatry a couple of years ago, led by my colleague Irini Kariotaki. And we collected, a lot of data. We also did one on the same one on guided internet interventions. And what we found for the unguided internet interventions, we didn't find any significant predictors. But for the guided internet interventions, we did find significant predictors. And exactly the opposite of what you would expect is that all the participants had a better outcome than younger participants. We don't know why that is. You would think that younger people are technologically better, but we didn't find better effects. So it's exactly the opposite. We found that ethnic minorities, that the effects are lower there. And we also found that the more severe the depression is, the better the outcomes. That's also not what you would think. Because for internet interventions, you usually think, okay, that's nice, but mostly for people with mild depression. But here we found that the more severe the depression is, the higher the effects. And that's not regression to the mean because this is all in comparison with control conditions. We do, what is important, there is a new IPD network meta-analysis coming in which we look at guided internet interventions, unguided internet interventions with control conditions. And then we look at all these individual predictors, and the results are really exciting. But it's not published yet, so I cannot talk about that. So this is another IPD network meta-analysis in which we collected all the data on CBT versus pharmacotherapy. And for example, in this meta-analysis, we found that baseline severity is not related to the outcome, meaning that CBT is also effective in severe depression, and it's not less effective than pharmacotherapy, for example. But I wanna, the last few minutes, I wanna show you where I think this field is going. Because one of the problems with IPD meta-analysis is that all these studies use different predictors and moderators. So then when you put it all together, you only have a few social demographic and clinical variables for which you can look at the outcomes. Still very useful. But if we start collecting the same outcome data and the same predictors and moderators across a large range of trials, then we can really make progress. And we did that a couple of years ago with my colleague, Toshi Furukawa. The paper is published in Psychotherapy and Psychosomatics. And that's only 3 trials on CBESP. CBESP is a specific type of therapy for chronic depression. And these 3 trials are large. So there are only 3 trials, but they have a lot of data. So I think we had something like 1,000 participants, which is good. But because these were large trials on a lot of people, they also had a lot of predictors and a lot of predictors and moderators in common. So here we could look in more detail what happens as a predictor. And what we did, we found several things. You can go to this URL here. I don't dare to do it through Zoom. So I have made a few screenshots, but this is what you get. And we're making many more of these sheets now. And you can look in the left side of the screen. You can put individual characteristics of patients in. And at the right side, you see the outcome for different treatments. So this is somebody with moderate baseline depression, very low baseline anxiety. You see here age and marital status and primary diagnosis, the prior depression type. And these were significant predictors. And so you can fill in individual characteristics of that one patient you want to predict the outcome for. And what you see here for this patient with these characteristics, it really doesn't matter whether they get CBESP, which is red, medication, which is the blue line, or the combination, which is the purple line. But if you look at the same patient, but then with higher baseline anxiety, then you get this. And there you see that for this patient, the combination is clearly better. And only CBESP is really the worst option here. And I mean, this kind of thing, you can build these models when you have enough individual patient data from randomized trials. And we're now developing this kind of individual prediction models for a lot of things. And I think this is the future where we're going. When you do a trial, you contribute your data to one big central database, and that will improve the models of personalized treatment, so to say, because this is in fact a personalized treatment. So I think this is pretty exciting stuff. Okay, future directions. I'm already talking too long, so I won't go in too much detail about this. I think we don't need more new treatments. We know therapies work, and I've seen over the years that all these new therapies are coming, but none of them has been shown to be more effective than existing therapies. So I don't think we need new therapies. I think prevention is a thing to focus on, because treatments are, as I said, the effects are limited, but prevention could additionally do something about the population disease burden of depression. We can also try to improve treatments. And if we do that, I certainly think we should focus on chronic and treatment-resistant depression. Because in these 750 trials we now have, about 30 are aimed at chronic or treatment-resistant depression, which is far too low, because this is the clinically most important target group. And of course, relapse, which is an important point. Then I think we should think about scaling up and simplifying treatments. I didn't go into that, but the issue is that if all therapies have comparable effects and treatment format doesn't matter so much, how can we minimize therapies without losing effects? And I think we can go a pretty long way. And there is a lot of research on, internet intervention is a way of minimizing interventions. But you can also think of using lay health counselors, or maybe even unguided interventions, because they have small effects. And then one thing I think that should be done is that we should do more research into the processes of treatments. But I've talked too long already. So if you want to know more about what research should be done on psychological treatments, I think you should read the paper of the Lancet Psychiatry Commission on psychological treatments to read more about that. And of course, I've not done all these meta-analyses alone, and there are all these people who have helped me over the years. And I want to thank you for your attention. And now I will stop sharing my screen.
So thank you so much, Dr. Cuijpers. You did an incredible job bringing us up to speed on the current status of psychotherapy research. And also such a lovely primer on meta-analytic approaches. So I will get us started with one question. You spoke about internet-based interventions, and I am assuming that most of those were interventions designed specifically for to be delivered via the internet. And with COVID, what's happened in clinical practice is many providers are simply taking existing psychotherapies and shifting them over to the internet. And I'm wondering to get your thoughts on that, and whether there's any research to talk about the efficacy of making those transitions.
Yeah, of course, these are empirical questions. So I don't know if you can just move everything to the internet. Most internet-based interventions are based on CBT, because CBT is it's very easy to make an internet-based intervention of it, because it's a lot of psychoeducation, homework assignments, explanation, that kind of thing. So it's relatively easy, but it doesn't necessarily have to be CBT. And as Myrna Weisman knows, there is also all kinds of initiatives to transform IPT to internet-based therapies. And there are even psychodynamic internet-based therapies. And the research on these therapies, they show that these other types of therapies can also be significant. I mean, the effects are still very good. So I don't think there is a reason not to move interventions to the internet.
In one of your earlier slides, you showed the effect sizes of various psychotherapies. And one of them was third wave psychotherapies. And I have to, I'm somewhat embarrassed to admit this, but I don't have a clear sense of what third wave psychotherapies are. And I was surprised to see such a large effect size, and hoping you could comment on that.
Yeah, third wave therapies, these are therapies, yeah, it's a broad family of therapies who consider themselves to be part of the CBT family, but try to improve the outcomes. And it's, for example, mindfulness-based CBT. There's a lot of research on that, where you combine traditional CBT with mindfulness. Acceptance and commitment therapy is another type of third wave. Metacognitive therapies. So each of them alone is not, there's not yet enough research on that. But if you pull them together, we do have enough to look at this group of studies. The effect sizes seem large, but the confidence intervals are broad. So we do not find any indication that they're more effective than other types of therapy.
Okay, great. There's a question from Karen McKinnon, who asks, you showed a category of comorbid medical illness. Can you speak to whether HIV stands out from other findings in any way?
Actually, we've just done an updated meta-analysis specifically for general medical disorders. We included, I think, 75 studies. And quite a few of them were on HIV, I think 13 or something, but we didn't find it different. I mean, what you see for these therapies is that the effect sizes are comparable across different general medical disorders, but that's the same effect size as you find for other target groups. So I think the lesson is that it really doesn't matter whether people have diabetes or HIV or no general medical disorder. Therapies are effective in each of these groups, and there's no reason to assume that there are differences in effects. And that's also true for HIV.
Okay. Our next question is from Andras Fuenmeyer, who asks, could you comment on the effect of cultural adaptations of psychotherapy, specifically when psychotherapies developed in high-income countries are given to low or middle-income countries?
Yeah, that's an issue. There is one meta-analysis not done by us who looked at cultural adaptation, and they found that cultural adaptation results in higher effect sizes. But I think this meta-analysis was not done correctly. So what we did in our own meta-analysis is we checked in the studies in non-Western countries whether the interventions were culturally adapted. And then we did a subgroup analysis in which we looked at the culturally adapted versus the non-culturally adapted. And we didn't find a significant difference. You have to be very careful with that, because it's very well possible that studies that they did a cultural adaptation but didn't report it in the paper because of there was not enough space in the paper. So we really don't know whether cultural adaptation whether that results in better effect size. On the other hand, I mean, it makes sense that if you apply an intervention in another culture, that you really look whether this is whether you can do that, so to say. But I think quite a few studies did, for example, IPT or CBT in non-Western countries. And I don't think they adapted very much, and these therapies still work. So I'm not sure what to think of that, but it seems that it's not really needed that therapies are developed in the country where they're applied, so to say. On the other hand, there are very few psychological treatments that are not developed in high-income countries. we only have a handful of those in our database.
Our next question is from Brian Fallon, who asks, for internet-based guided therapy, does the amount or duration of the guidance make a difference? For example, some researchers give 2 weeks of support for the CBT and then leave it to the patient to contact them on an as-needed basis.
Yeah, so in our studies, we differentiate between guided and unguided internet interventions. And guided usually means that there is, a psychologist, or it doesn't have to be somebody who is trained as a clinical psychologist or a therapist. It can be students. So master students or bachelor students who are trained. And the intensity of the support is pretty low. So in our trials on internet interventions, they consist of 5 or 6 modules, which are weekly, and then a student gives 20 minutes per week support by email or something. So that's pretty low. But it's I mean, we separate guided from unguided, but in fact it's a whole spectrum. And where does guidance go to unguided? I mean, that's a gray area. And if you say, well, we only give support in the first 2 weeks and then not, I don't know whether is that guided or unguided? I think I would say it is guided because you have a personal connection with somebody. But I mean, it's a matter of, it's the gray area. It's a gray area, yeah.
I believe that Myrna Weissman also has a question. Simon, I'm not sure if you're able to add Dr. Weissman to the panel so that she could ask it directly.
No problem.
Okay. So while Simon is adding Dr. Weissman to the panel, let me ask another question from Dr. Ralph Wharton, who asked if you could comment on relapse rates, for example, follow-up after 2 to 5 years.
That's a very good question. Unfortunately, there is not so much research on long-term follow-up of psychotherapies. There are a few studies. Hi, Myrna.
Hi, sorry.
The relapse rates are high. I think the estimates are 50% in 2 years. Probably it's a little lower, but actually we don't have enough evidence from randomized trials to be certain about that. We did one meta-analysis on 8 studies of CBT where we looked at 1 year follow-up, which was complicated because so we only had 8 studies on that. So that to indicate how few research is on the long-term effects. But we did find, of course, there's more, but these were studies comparing CBT with combined treatment and pharmacotherapy. And we found that actually CBT had more effects than drugs at 1 year follow-up. But unfortunately, the data on relapse rates are, I'm afraid I cannot give them because the data are just not there.
So, Dr. Weissman, would you like to ask the next question?
Yeah. First of all, I want to thank you, Pim. There's no one else like you that is doing what you're doing, and it's a great relief to have it. It also gives us big opportunities to argue and to also be overwhelmed by what you present. So I want to just ask you, first of all, I fully agree with the idea of a central database. We're going to have a problem here in the United States, though, because clinical trials of psychotherapy, unless they have a brain target, we're told won't be funded. So these studies may for a while have to come from elsewhere. I wonder whether you have included implementation studies in any of your analysis and whether you've done anything on implementation. And I have one other question, lots of questions. you showed that there were no differences between psychotherapies, that they all had a similar effects, which I think is probably true. I believe your findings. But if we did studies of different kinds of SSRIs on depressed patients, we'd probably find the same thing. So how do we translate that into clinical practice? Or how do you think there should be just one overall psychotherapy? Do you see value in having different ones? And it's a big question, and one we struggled with the commission you and I were on.
First, the implementation issue. We include all randomized trials. So if it is a trial on implementing an intervention on a large scale in a health system, then we have included it. But this is also a continuum. So you have on the one hand a very strict, almost lab efficacy studies, and you have the large randomized trials in large populations done in clinical practice. And it's, I've looked at it a number of years ago. We don't really find a difference between them. But John Weiss, I did a meta-analysis recently with him, and he says that there is a difference between the efficacy and the implementation studies. So that's one of the things I want to do in the next year, so to say.
Oh, good. I look forward to it.
Yeah. The second question, what again was it about?
No, well, there's no differences between the psychotherapies, and there would be no difference in SSRIs. So how do you translate that?
Yeah, what I think is that I wrote a paper about that in depression and anxiety, I think in 2013. I still think, I mean, from a patient perspective, you want the best treatment. And of course, it's probably true that all treatments have comparable effects. But for when you work with patients, you don't want to take chances. So I think you should apply therapies for which the best evidence is available. And that's CBT, of course, but also behavioral activation therapy, interpersonal psychotherapy, maybe problem solving. And because for these therapies, we have comparisons with drugs. We have comparisons with combined treatments. We know a little about the longer term effects. And so for psychodynamic therapy, we have very little research. Probably it has comparable effects, but I still think when you work with patients, you should work with the therapies that have the best evidence.
Thank you for coming. I hope in person next time.
Yes, me too.
Okay, so I think this is our last question, and it's from Dr. Jeffrey Miller, who writes, an older study from the 1980s, the collaborative study, examined possible differential predictors of treatment outcomes to CBT versus IPT, specifically magnitude of cognitive or social dysfunction at baseline. Do the common assessments you were including in the CBASP versus medical trial include comparable measures of baseline cognitive and social dysfunction? And Dr. Miller also notes, thank you for your amazing work and your talk.
I'm afraid in the CBASP study, I cannot remember whether we had this variable, but if it was there, it would have been examined, and then if it's there, we didn't find a significant, as a significant predictor. The problem with the collaborative trial is that for those days, that was an amazing study. But nowadays, we would say it's still a small, underpowered trial, which doesn't have sufficient power to examine predictors of outcome. So all these predictors that have been examined in the collaborative trial are probably underpowered, meaning that could be a chance finding. Or if you don't find a significant outcome, it can still be there, although you didn't find it. So that's the problem when you look at predictors of outcome.
Okay, great. So wanted to thank you again for such a wonderful talk and for taking the time to present to us. And I know that we had to reschedule your talk because of COVID, so thank you so much for your patience. I also wanted to underscore your commitment to open science and really appreciated your efforts to make all of your work and your studies and data as much as possible publicly available. It's really terrific to do that. So with that, I think we will end there. Thank you everyone for coming. Try not to check the news feeds compulsively, and we'll get through these next few days and look forward to grand rounds again in 2 weeks. Take care.
Bye.